Welcome to the deep dive. Today we're tackling a really critical area in vascular surgery. It's about what happens when a patient needs a bypass, but their own blood vessels just aren't up to the job.
Right, when autogenous options are off the table.
Exactly.
Yeah.
So we're going to delve into these non-autogenous biologic grafts. That's grafts from biological materials, not from the patient.
Yep. Specifically allografts, which are same species, like human to human.
Xenografts, which are different species, like animal to human.
Correct. And it's a field with a pretty long history, actually.
Oh, yeah.
Yeah, back in the early 20th century, people started experimenting with animals. Then the First World War saw some of the first human uses of allografts.
Wow, really? During the war?
Yeah, and by the mid-century, we started seeing actual clinical series using both artery and vein allografts. The initial hope was huge.
I bet, like an off-the-shelf solution.
Exactly. The dream was this ideal, readily available fix for all sorts of vascular problems.
It makes sense. Imagine having vessels ready. Different sizes, easy to handle, performing just like your own. It's a really appealing idea.
Definitely.
So for this deep dive, our mission is really to unpack these biologic grafts. We want to look at, what they are, how they're prepared,
How they're used clinically.
and crucially, what the real-world outcomes have actually been. Because ultimately, we want to figure out why, despite all that promise, all that research,
Nearly a century of it.
right, why they haven't quite become the holy grail of vascular surgery. Okay, so where should we start? Maybe with cryopreserved allografts?
Sounds good. But maybe we should first touch on the fresh vascular allografts, because that's where it began.
Ah, okay, the early days.
Exactly. Those initial animal studies, particularly with vein allografts in dogs, they showed kind of mixed results.
Mixed how?
Well, some grafts stayed open for a decent while, but they often saw problems like intimal proliferation, that's a thickening inside the vessel lining.
Right, narrows the channel.
Precisely. And also inflammation, weakening of the wall, things you don't want.
And did that carry over into humans?
Unfortunately, yes. When fresh vein allografts were used for bypasses below the groin, they tended to fail pretty often.
Fail how? Blocking up.
Either blocking up, yeah, or becoming aneurysmal, bulging out. And interestingly, there was an early thought about ABO blood type matching.
Did that help?
Not really. Later research didn't show it made much difference. And fresh arterial allografts, especially in the aorta, they turned out to be quite immunogenic.
Meaning the body really attacked them.
Yeah, triggered a significant immune response.
So it wasn't just the body's reaction then. It sounds like just using fresh grafts was tricky.
Absolutely. The logistics were a nightmare. Availability was scarce, unpredictable.
You could just order one up.
Exactly. So there was a huge need for reliable ways to store them.
Yeah.
And that really drove the development of preservation techniques.
Which led to freezing.
Right. Cryopreservation, deep freezing, essentially became the most common method.
Okay, so how does that work? How do you freeze a blood vessel without, wrecking it?
It's a very controlled process. The big challenge is ice crystal formation during freezing. Water inside and outside the cells freezes differently, which can dehydrate or even burst the cells.
Ouch. So how do you stop that?
With cryoprotectants, things like dimethyl sulfoxide, DMSO, or glycerol.
Right.
These chemicals get into the cells and basically reduce that difference in water potential, protecting them from ice damage.
So they act like antifreeze for the cells.
Kind of, yeah. And over the last few decades, these techniques have gotten pretty sophisticated, commercially standardized.
What factors matter?
Oh, lots of things. The type and concentration of the cryoprotectant, how fast you freeze it. Some evidence suggests rapid freezing might be better.
Interesting.
The super low storage temperature, how long it's stored. Some research even looked at adding things like chondroitin sulfate to maybe help keep the vein viable longer.
Fascinating stuff. Okay,
Yeah.
So you freeze it carefully, then you thaw it out. What's the vessel actually like afterwards? Microscopically, functionally.
Well, the good news is that key mechanical properties like elasticity, compliance, how stretchy it is, seem to be generally well preserved.
That's important, obviously.
Crucial for function. But on the cellular level, you do see changes. The endothelium, that vital inner lining, its overall structure might remain, but you see changes like little surface projections, fluid-filled sacs.
Not ideal.
No. And over time, this can lead to some loss of those endothelial cells, which is a problem because that lining is key for preventing clots and keeping the vessel healthy.
Can it regrow? like our own vessels.
That's the issue. Allografts seem to have a very limited ability to re-endothelialize, to repair that lining. And this damaged surface also seems to pick up LDL cholesterol faster.
Okay, so the lining is compromised. What about other functions, like relaxing or clotting?
The ability of the endothelium to help the vessel relax vasodilatory function, that's often a bit diminished after cryopreservation.
And clot.
Well, it doesn't seem to increase initial platelet stickiness, but it does decrease the activity of thrombomodulin,
Which is?
a key protein that helps regulate clotting, keeps it in check. Fibrinolytic activity, breaking down clots, seems okay initially, but might decline with longer storage.
What about the muscle layer? The media?
The smooth muscle cells there generally look okay, though some subtle changes are seen in animal models. Interestingly, while they might become more synthetically active, collagen production, the structural protein, can actually go down in cryopreserved veins.
Weird.
And while they might still contract okay, their ability to relax in response to nitric oxide, a key signal, can be impaired.
Okay, so the freezing process itself causes some changes.
Yeah.
But these are allografts, grafts from someone else. So the immune system must get involved too, right?
Absolutely. That's the fundamental difference compared to using the patient's own vein. An allograft will trigger an immune response.
How does that look in the graft?
Well, that endothelial loss we mentioned isn't easily repaired. Under the microscope, you see exposed stuff underneath that triggers immune cells. Smooth muscle cell viability goes down. You see significant scarring in the media. The elastic fibers get disrupted.
So it loses its stretchiness.
Exactly. And even cell death, necrosis within the media. Plus, you see immune cells, lymphocytes invading the vessel wall. You don't typically see that with autografts.
But I thought the idea was that cryopreservation suppressed the immune reaction.
That was the initial belief, yeah.
Hmm.
That it was relatively mild and freezing took care of it. But the evidence now is pretty clear that vascular allografts do cause a substantial immune response.
How so?
The endothelial cells have surface proteins that trigger a cell-mediated attack. And there's also an antibody response against donor antigens.
So it's a double whammy.
Pretty much. Animal studies clearly show rejection fibrosis, immune cells flooding in allografts, but not autografts. And human studies, looking at failed cryopreserved saphenous veins, they find lots of inflammatory cells, activated T lymphocytes. The immune system is definitely reacting.
Okay, the body knows it's foreign. So what if surgeons tried to manage this immune attack and maybe make the grafts last longer?
Several things. One early idea was matching ABO blood groups.
Like for organ transplants, did it work?
Well, a big recent study looked at this and found no real impact on death, graft blockage, rupture, or aneurysm formation, so probably not.
What about immunosuppression drugs, like transplant patients take?
Yeah, drugs like cyclosporine, azathioprine, they've been studied mostly in animals where they showed some promise in reducing rejection.
But in humans?
Mixed results, really. One prospective trial using low-dose azathioprine for leg bypasses didn't show a significant boost in patency at 1 year, though it did reduce some immune cells in the graft.
Any other trials?
Another, smaller trial used a stronger cocktail of immunosuppressants. It did report better patency, but also more complications, including aneurysms developing in the grafts.
So a trade-off again.
Seems like it.
Yeah.
And using cyclosporine for infected aortic grafts replaced with allografts, it dampened the antibody response but didn't seem to affect patency or complications. There's even a conflicting idea that maybe low-dose cyclosporine could help reduce rejection and encourage the recipient's cells to line the graft.
Wow, it sounds incredibly complicated. No easy answers for stopping the immune response.
Not yet, no.
What about the risk of the patient becoming sensitized, developing antibodies against the donor tissue?
That's a really important point, especially when using cryopreserved femoral vein allografts for dialysis access.
Why specifically those?
Because if that patient later needs a kidney transplant, those antibodies could cause problems. And studies have shown fairly high rates of this allosensitization with femoral vein grafts for dialysis.
Is there a way around that?
Possibly. If the graft is processed further to remove the cellular bits, the risk seems to go way down.
Decellularization.
Exactly. And that idea, minimizing the immune trigger by changing the graft itself, leads us right into structurally modified biologic grafts.
Okay, so the goal here is different. Instead of just preserving the vessel, you're actively changing it.
Right. The aim is to create grafts that are durable, don't cause a big immune reaction, and are maybe easier to make and store than cryopreserved ones.
How did they first try doing that?
Some of the earliest attempts back in the 50s were pretty aggressive. They used enzymes like ficin from figs
Makes sense.
to basically digest away the muscle and elastic parts of animal arteries, trying to get rid of the immunogenic proteins.
Leaving just the scaffolding.
Essentially, yeah, a collagen tube. Then they strengthened that scaffold using tanning agents like dialdehyde starch, cross-linking it.
Like tanning leather.
Similar principle, yeah. Then they'd sterilize it and store it in chemicals.
Sounds much more involved than freezing. Let's talk specifics. What about the bovine carotid artery graft, the BCA xenograft?
That was one of the first modified grafts used clinically. After animal tests, they started using them in patients with leg artery blockages.
How did they do?
Well, they didn't rupture, but they had issues with that inner lining thickening. Again, neo-intimal hyperplasia and long-term patency wasn't great.
Any other problems?
Yeah. Later on, unacceptably high rates of infection and aneurysm formation cropped up. That led them to switch to glutaraldehyde tanning methods.
Is it still used?
Yes, glutaraldehyde tanning is standard for the BCA xenografts made today. They're commercially available now, and surgeons need to know how to handle them.
Okay. What about the bovine mesenteric vein BMV xenograft?
That one uses a proprietary process, also involving glutaraldehyde cross-linking for stability and then gamma radiation for sterilization.
And it's used clinically, too.
Yes, it's found its niche in certain applications as well.
And then there's the human umbilical vein, the HUV graft.
Yeah.
That sounds unique.
It really is. First used clinically in the 70s. Umbilical veins have some nice properties, consistent size, no valves, no branches.
That's convenient for a surgeon.
Can be. The preparation involved isolating the vein, sometimes enzymatically, sometimes mechanically stripping it, and then often a polyester mesh was sutured around it for extra support.
Why the mesh?
To give it strength.
Yeah.
And the idea was that pre-treating it with glutaraldehyde would mask the antigen sites, making it less immunogenic.
Did it work? Is it still used?
Well, the manufacture was actually stopped back in 2005.
Oh, why?
FDA guidelines changed regarding these combination tissue device products. So it's not an option anymore, but its history is relevant.
Gotcha. Were there other, maybe less common biological sources people looked at?
Oh, definitely. The search for the perfect graft led people to try all sorts of things in animal models.
Like what?
Grafts made from pericardium, the sac around the heart, even small intestinal submucosa. And chemically modified ureters from humans and cows were also studied. Some limited success in animals, even a small human trial suggesting they might be okay for dialysis access if other options failed.
It's amazing the ingenuity. Okay, so we've got all these different types. Let's shift focus. Where do they actually get used in surgery today? What are the main jobs for biologic grafts?
Broadly speaking, there are three main clinical scenarios where they really come into play.
Okay, number one.
Extremity bypass surgery, especially when the patient doesn't have a good vein of their own to use, and particularly for those tougher bypasses below the knee, the infrageniculate ones.
Which grafts are used there?
We see cryopreserved saphenous vein, CSV, cryopreserved femoropopliteal artery, CFA, historically the HUV graft, and also the BCA and BMV xenografts. Success varies, though.
Okay. Scenario number two.
Arteriovenous, or AV, access for hemodialysis, again for patients who don't have suitable native veins for a standard fistula.
And the grafts used for that?
Cryopreserved femoral vein, CFV, the BCA xenografts, sometimes bovine ureter xenografts, and the BMV xenograft.
And the third main use?
This is a big one, replacing infected prosthetic grafts, especially aortic grafts.
Because putting in new plastic isn't great if there's infection.
Exactly. Biologic grafts are inherently more resistant to infection, so cryopreserved aortic allografts, CFV allografts, and CSV allografts are used in these really complex, high-risk situations.
That makes sense. Okay, let's dig into the prep work. How are these actually made ready for surgery, starting again with the cryopreserved allografts?
Oh, right. This is usually done by specialized tissue banks or companies. Many have their own proprietary methods, but the general process is quite involved.
Walk us through it.
It starts with harvesting vessels, saphenous vein, femoral vein, arteries from carefully screened multi-organ donors.
Rigorous screening, I assume.
Absolutely. Testing for viruses, bacteria, fungi. Then, any side branches on the vessel are tied off. They're measured precisely for length and diameter.
Then what?
More pathogen testing and antibiotic rinse, then they're soaked in that cryoprotectant solution we talked about.
The DMSO or glycerol?
Right. Then they're packaged and stored in the vapor phase of liquid nitrogen super cold, like -110 degrees C to -96 degrees C.
Wow. How do they get to the hospital?
For shipping and storage at the hospital, they're often kept in DMSO around 996 degrees C until needed.
And thawing. Just leave it out.
No, it's a rapid thaw, usually in a warm water bath, 37 degrees C to 42 degrees C, for about 20 minutes. Then a series of rinses following the manufacturer's instructions to get rid of the cryoprotectant before the surgeon implants it.
Okay. Are there specific things to know about prepping, say, a saphenous vein versus a femoral vein or an artery allograft?
Yeah, there are nuances. Cryopreserved saphenous veins, CSV, come in various lengths, usually 3 to 5 millimeters wide. Handling-wise, they feel a lot like the patient's own vein,
How are they put in for leg bypass?
usually reversed end-to-end and placed in a tunnel under the skin. Interestingly, one big study suggested that routine ultrasound checks after surgery didn't really help predict if they'd stay open long-term.
Huh. What about the femoral veins, CFE?
They're generally shorter, maybe under 25 centimeters, and a bit wider, 5 to 7 millimeters. Their main use has been for dialysis access, especially in tricky situations like infected prosthetic grafts.
How are they used for access?
Usually reversed and often tapered, the smaller end goes to the artery, maybe a 5 millimeter connection, to try and prevent steal syndrome in the hand,
Seal syndrome.
where the access steals too much blood flow from the hand. These CFE grafts need time to mature, maybe 3-4 weeks, before dialysis needles can go in. And fixing them later if problems arise can be tough because the wall is thin and there's often scar tissue around.
Right. And the arterial allografts, used for infected aortas.
Mostly, yes. Replacing a big, high-pressure artery like the aorta in an infected field is demanding. These grafts have to be tough.
What's key during surgery?
Following thawing instructions to the letter, choosing the right length graft, making sure the connections, the anastomoses, are tension-free, using strong polypropylene sutures that grab the whole graft wall. Getting rid of all infected tissue is critical. Good drainage.
Any extra tricks?
Sometimes surgeons reinforce the suture lines with strips of allograft material or use antibiotic-loaded fibrin glue for sealing and local antibiotics. Covering the graft with healthy tissue, like muscle or omentum flaps, can also help protect it and promote healing.
Okay, quite involved. What about prepping the modified grafts, the HUV, BCA, BMV?
Well, the HUV graft, the umbilical vein one, used to come stored in 50% ethanol on a sort of glass rod.
Sounds delicate.
It was. Didn't handle standard surgical clamps well, needed super careful handling when tunneling it, maybe using a special tube to guide it, and controlling blood flow with tourniquets instead of clamps was better.
And sewing it in.
You had to make sure your stitches caught both the vein and that outer dacron mesh support to avoid pseudoaneurysms, false bulges at the connections. But again, it's not made anymore.
Okay, the bovine carotid, BCA.
That usually comes in a container with propylene oxide and alcohol solution. It feels quite like a real artery, good compliance, relatively easy to handle, comes in different sizes. Needs a good rinse with sterile saline right before use to wash off the storage fluid.
And the bovine mesenix vein, BMV.
That one's shipped in sterile saline, also various sizes. It handles nicely, quite similar to a human saphenous vein, so surgeons are comfortable with it. And like the BCA, it needs a saline rinse before implanting.
All right, we've covered the what, the how, the where. Now for the big question. How well do they actually work? What are the clinical outcomes? Let's start with the cryopreserved saphenous vein, CSV, the workhorse for leg bypass when there's no native vein.
Okay. There are a lot of studies on CSVs for infrainguinal bypass, but interpreting them is tricky.
Why is that?
Well, different tissue banks might use slightly different freezing methods. Patient groups vary hugely between studies. Where the bypass starts and ends differs. Whether they used anticoagulants or immunosuppressants varies.
And mostly retrospective studies, looking back at data.
Exactly, which can introduce bias. But generally speaking, the graft patency, how long they stay open, tends to be fairly low in most retrospective series.
How low are we talking?
One of the biggest studies reported only about 30% primary patency at 1 year.
Oof. Only 30% still working after a year.
Roughly, yes. Now, contrast that with a smaller prospective study that reported much higher patency.
Nice.
But they used a really intensive anticoagulation plan in that study and specific ways of connecting the far end, so maybe that made the difference.
What about fixing them if they start to fail? Secondary procedures.
Unfortunately, trying to reopen failing CSV grafts usually doesn't provide much long-term benefit. Once they block, they're often just abandoned. If the patient needs more surgery later, it's usually a whole new bypass with something else.
Are there factors that predict whether a CSV graft will fail?
Several things have been looked at. Diabetes seems to consistently be bad news, lower patency rates for diabetic patients.
Okay, what else?
Interestingly, things like age, Gender, high blood pressure, smoking history, kidney problems, the reason for the surgery. Even where the bypass was connected below the knee, none of those showed a significant effect on patency in one large analysis.
Really? Site didn't matter.
Not in that study, surprisingly, but using secondary grafts or composite grafts where you stitch shorter vein pieces together, that was linked to significantly worse patency.
Makes sense. More connections. Any good news?
Well, some recent research hints that statins, the cholesterol drugs, might actually help improve CSV graft patency.
Oh, that is interesting. Needs more study, I guess.
Definitely.
What about directly trying to prevent clots or rejection, blood thinners, immune suppression for CSVs?
Anticoagulation's been studied a lot. In most reports, just using standard aspirin or warfarin alone or together hasn't really shown a big improvement in CSV patency overall.
But that one study with high rates.
Right, that one used a really aggressive combination of blood thinners, so maybe intensity is key.
Yeah.
But we really need a proper randomized trial to know for sure.
And immunosuppression, like the azathioprine trial you mentioned.
Yeah, that prospective trial with low-dose azathioprine didn't show significantly better patency at 1 year. The other small trial with stronger drugs did show better patency, but also more complications, like aneurysms.
So the risks seem to outweigh the benefits.
For routine use, probably yes. Given the potential side effects of long-term immunosuppression, it's not generally justified based on current evidence.
Okay, so keeping the graft open long-term is tough. But what about the main goal, saving the limb? Do CSVs work well enough for that?
That's a key point. Even with those less than ideal patency rates, CSV allografts generally have acceptable limb salvage rates for patients with critical limb ischemia.
What kind of rates?
The biggest study reported about 71% limb salvage at 2 years. Another found around 64% at 5 years.
So the graft might fail, but the leg is saved more often. How does that work?
Couple of reasons. Even if the CSV blocks, maybe a second bypass with something else is possible later. Or perhaps the CSV stayed open just long enough for ulcers on the leg or foot to heal, and those ulcers might not come back right away even if the graft fails later.
Timing is everything.
Seems so. Also, where the bypass connects matters for limb salvage. Connecting to the popliteal artery above the knee generally does better than connecting way down to the tibial arteries. And older patients, unfortunately, tend to have a higher risk of amputation even with a bypass.
Okay. One more thing with grafts that do stay open aneurysms. You mentioned that. Is it a big worry with CSVs?
It is, yes. If they stay patent long enough, they can degenerate and bulge out. It's thought to be related to that ongoing low-level immune response.
How often does it happen?
Hard to say exactly because many block early, but reported rates vary. One study found 44% developed aneurysms by 2 years among those still open. Another found 25% at 2.5 years.
And they can rupture.
They have, yes, which can be very serious. So the recommendation is close surveillance checkups, scans for patients whose CSV grafts stay open long-term, and consider fixing an aneurysm preemptively if it gets big.
Okay, so summing up CSVs for leg bypass. Valuable when there's no other vein, but not perfect. Limited patency, worse with diabetes. Standard blood thinners don't seem to be the magic bullet, but they are useful in infections for really distal bypasses and can buy healing time for ulcers. Still in demand despite the cost.
Yeah, that's a good summary.
Right. Let's switch gears to cryopreserved femoral vein allograft CFE. Used more for dialysis access, you said. How do they fare?
Primarily, yes. Usually in tough situations, infected prosthetic access, multiple prior failures, poor veins in the arm.
And the outcomes?
Patency. Some studies report reasonable primary and secondary patency at 1 year for dialysis use, and infection rates have been relatively low in some series, but pseudoaneurysms at the connections can definitely happen.
How do they compare to standard PTFE grafts for access?
It's a mixed bag in the literature. Some studies show similar patency, maybe fewer infections with CFE, but more aneurysms. Others raise concerns about CFEs needing more procedures to keep them open and having more aneurysm issues.
Any major red flags?
One study was quite alarming. It reported a really high infection rate with CFV for access, especially when placed in the thigh. And those infected thigh grafts had a high rate of rupturing.
Yikes. So what's the verdict on CFV for dialysis access?
The consensus now is they don't have a primary role, not the first choice, but maybe a secondary option in very select, difficult cases, like infected prosthetic access with no other choice.
And the sensitization.
It shouldn't concern. Avoid them in potential kidney transplant candidates unless they're decellularized. Also, be quick to fix any symptomatic pseudoaneurysms, and probably avoid putting them in the thigh if you can help it.
You mentioned other uses emerging.
Yeah, more recently, some promising early results using CFV for complex venous reconstructions during big cancer surgeries, like Whipple's or liver transplants. So maybe their role will expand.
Interesting. Okay, what about cryopreserved arterial allografts? You mentioned aortic use, but elsewhere, leg bypass.
For leg bypass, generally poor results, low patency, prone to aneurysms. They don't seem better than saphenous vein allografts. Plus, they're often short, meaning you might need to stitch pieces together, which adds complexity.
So mainly for aortic infections.
That's been their main niche. Fresh aortic allografts were used initially with some success. Comparing fresh versus cryopreserved, one study found no difference. Another noted long-term issues like rupture with fresh ones.
So what do the bigger studies on cryopreserved aortic allografts for infection show?
They show it's a high-risk operation, high rates of death around the time of surgery, high complication rates, including rupture and the graft stretching out, dilating. But some studies also show acceptable longer-term freedom from major aortic problems in the patients who get through that initial period. The largest study actually suggested maybe lower risks than earlier reports, and a recent meta-analysis concluded they are reasonably safe and durable overall for this very tough problem.
How do they stack up against other options for infected aortic grafts, like bypasses around the infection or putting in a new plastic graft?
Cryoaortic allografts definitely have a role, but exactly where they fit is still being defined. The risks of dilatation and rupture are real, and we don't have standard ways to monitor them long-term yet. Maybe future immunosuppression strategies could improve things.
Okay, let's move to the modified grafts. Human umbilical vein, HUV. What were its outcomes like before it was discontinued?
Early on, for leg bypass, results looked quite good. Decent 5-year patency and limb salvage reported, but also a noticeable rate of aneurysm formation over time.
Did they try to fix the aneurysm problem?
Yes, a second-generation graft was made with a tighter mesh support. Early results look better improved patency, no aneurysms in one series.
But the big trial.
Right, the largest randomized trial compared HUV to saphenous vein and PTFE for above-knee bypass. HUV beat PTFE on patency, but was much worse than saphenous vein, and HUV had more early clotting and more amputations.
So it never really took off.
Not really. Despite okay results, sometimes it didn't become mainstream, and now it's off the market. But surgeons might still see patients who have one.
Got it. What about the bovine carotid artery, BCA? How did that perform?
Initially tried for dialysis access. It tolerated needles okay, provided good flow. Patency rates varied, though.
Compared to PTFE for access?
Mixed results again. Some studies showed no difference. Others favored PTFE for staying open. BCA grafts were linked to higher rates of infection and aneurysms, though.
Any other downsides?
They tend to cause a lot of scar tissue around them, making them hard to remove if they get infected, and they're usually more expensive than PTFE. These factors limited their widespread use for access.
What about for leg bypass?
Limited use there, too. Some studies reported high degeneration rates, another showed better patency above the knee than below, but concerns about short lengths, PTFE being available and cheaper, and the degeneration risk meant they never gained much traction for leg bypasses.
Okay, last one. The bovine mesenteric vein, BMV xenograft. How is that done?
It's shown success for dialysis access, especially in patients with lots of previous failures using synthetics.
What do the numbers look like?
Some series report decent primary and secondary patency, low aneurysm rates. Infections can still happen, of course.
How does it compare to PTFE for access?
One big registry study found similar primary patency, but actually higher secondary patency for BMV.
Meaning easier to fix and keep going.
Potentially, yes. That study also found less infection with BMV, but a similar rate of pseudoaneurysms. However,
Another but?
some cases of the BMV graft slowly stretching out, dilating, have been reported. We don't fully know the long-term significance of that yet. Needs more research.
And for leg bypass, BMV any good there?
No, results have been limited and generally poor. High early failure rates. So BMV is generally not recommended for infanguinal bypass.
Okay, wow. It's really clear that while these biologic grafts are useful tools in certain tricky spots,
Absolutely essential sometimes.
they definitely haven't replaced the patient's own vein as the go-to option. It really sounds like the future might lie elsewhere.
Indeed. Because of all these limitations with current xenografts and allografts, there's a huge amount of research focused now on vascular tissue engineering.
Golden vessels in the lab.
Essentially, yes. Using the patient's own cells, seeding them onto biocompatible scaffolds, The big hope there is to finally get rid of the immunogenicity and maybe the infection risk, too.
Are these being used yet?
Early clinical trials are happening now, generating a lot of excitement.
So pulling it all together then, biologic grafts, valuable tools, absolutely critical in specific scenarios like no autogenous vein available or dealing with infection.
Couldn't do without them sometimes.
But they haven't become the universal solution because of issues like variable patency, degeneration risk, infection risk, the immune response with allografts, and often higher cost.
That sums it up well.
And the future seems pointed towards tissue engineering, trying to create that truly ideal graft.
That's the direction things are moving, yes. It's striking how the field keeps evolving, isn't it? From those first animal tests, through cryopreservation, structural modification.
And now maybe lab-grown vessels.
Exactly. It shows the relentless drive to find better solutions for patients with these difficult vascular problems.
Absolutely. And, when you think about all the complexity, all the trade-offs we've discussed for each graft type, it really makes you wonder, doesn't it? How might future developments in personalized medicine, maybe tailoring grafts somehow to the individual, combined with these leaps in tissue engineering, how might that completely change the game for vascular bypass surgery in the years ahead?
It's a fascinating question. The potential is enormous.
Definitely something to keep an eye on. Well, thank you for walking us through this incredibly complex but important area of biologic grafts.
My pleasure.